If you're building your ABA company and you're tired of guessing, this is for you. We built the EBCBA blueprint to give you real structure, systems, and support without the fluff. Details are in the description.
We've got Rose and Michael from ABA Compliance Solutions. We're going to be talking about compliance. It's a really important topic. We do assessments all the time for ABA companies, and we always basically look at their gaps and see like where they're missing out on compliance. And in a lot of cases, like people just don't know. They don't know what they don't know. So I'm really excited to have this. So if you want to take it away.
Yeah. All right. Thanks, Josh. I'm Rose Feddock. This is my business partner, Michael Fabrizio. We're with ABA Compliance Solutions. And as Josh mentioned, we're going to be talking about how building compliance systems can move your organization from just a passionate startup into something more sustainable. Talk a little bit about us. Michael, I'll let you take this one over.
Yeah. So Rose and I have been practicing behavior analyst in the clinical sense, working primarily with kids with autism, although we also worked with other clinical populations as well across our clinical careers. We did that for about 20 and 30 years, respectively. We were there before board certification. We were there before licensure, et cetera. We're also board certified. We're also licensed as behavior analysts. And then in addition to that, we went on and collected some additional credentials, professional credentials, specifically related to compliance. I also had the pleasure of being on campus faculty at both the University of North Texas in their Department of Behavior Analysis and in the Department of Applied Behavior Analysis at the Chicago School of Professional Psychology for their first several cohorts of students. And that's actually where Rose and I met each other. Rose is a former compliance coordinator and the director of standards development for the BHCOE. We have consulted both clinical consultation and compliance consultation with a range of different groups like ABA organizations, primarily school districts, legal teams, insurance companies, et cetera. And I think we each played a role and supported ABA moving into the field, becoming basically a type of healthcare. We both played minor roles in that in our respective locations and supported that.
Yeah. And a little bit about where Michael and I have worked together. So as Michael mentioned, I met him in grad school and he said, hey, you want to come out to Seattle? And I said, no, I don't like Seattle. And then I moved to Seattle and worked with Michael. So we worked together clinically in his private practice. And then as that shift into healthcare was coming on, Michael and his business partner had the really good foresight of knowing that means something. The fact that our practice might look similar clinically, the fact that we're taking health insurance as a primary funding source really does shift something. And so they brought me in as compliance officer. We've worked together clinically and now in this compliance world for quite a while. So we wanted to start with telling a little story from our time together in that practice. Michael, do you want to talk a little bit about the practice and then we'll tell the story?
Yeah, so this was the private practice that I co-owned with my former business partner. I no longer own it. She bought me out when I decided to stop my clinical work and turn to compliance full-time. We were the second oldest ABA practice in the Seattle area, so we had a lot of long history. About $3 million annually in revenue. We had very robust clinical systems, and we had a pretty well-established compliance program. And this story we're going to tell, it's important, I think, to understand this is just after ABA became healthcare.
So in Washington, health coverage came in about 2013, and this story started in 2016.
Okay, so about 2016.
Yeah. So in terms of the well-established compliance program, one of the things you'll always hear us talking about is like, there is no such thing as I have reached compliance. Yay, I'm compliant. That's not a thing.
Compliance is a condition you treat. It's not a goal you meet. It's a condition you treat, not a goal you meet.
It's diabetes. You will have it and you will work on it forever.
We have to spin that somehow, workshop it.
Somehow more pleasant, yeah. So for the context where we were at the time, just a couple of years into accepting health insurance, which also means those health insurance providers were just a couple of years into even talking to us, paying for things at 30 hours a week of service, for knowing what our documentation might or might not look like. We wanted just context always matters. And so situating it there. And in terms of the well-established compliance program, I think we had a really good set of compliance systems in place. And as we grew and learned more about what a compliance program should have, we knew how to categorize some of those systems a little bit better and clean them up.
That's well said.
Yeah. So here we are. It's 2016. We've been providing services for multiple payers, but this payer in particular, I think we've been providing services with them for a good couple of years. So we get a letter. We get the audit letter. I'm sure some of you have already had the experience of the letter comes and you read it. You have that feeling in your stomach. What am I going to do with this?
It was a small sample, was the first letter that we got.
Yeah. So they just say, hey, we want to see some of your documentation. Now, Michael and I, for some clinical context, are both in the whole practice was precision teachers. For those of you that's not your jam, that means that most of what we saw as the most important clinical documentation was on the graph data on the standard acceleration chart. We had some other documentation systems, but from our perspective, anything you ever needed to know about a client was on those graphs. So we get the demand letter from the insurance company. They say, hey, let's see some of these charts. We send them all the documentation we have, which like now and where I sit today in 2026, so 10 years later, I can only imagine what they thought when they got this pile of graph data on a type of graph that honestly, lots of behavior analysts never look at, wouldn't know what to do with, let alone these poor auditors who got all this graph data. They looked at our documentation and they said, that's not documentation, let's see more. So then I think they, if I remember correctly, they expanded the audit, which is cautionary tale for everyone to know. If you don't send them everything they need from the beginning, they will not say, hey, do you have anything else to prove your case? What they're more likely to say is, I want to look at more clients. I want to expand the scope of what we're looking at. So that is in fact what they did. We sent them more of what we had sent them in the, oh, you have more kids you want to look at? Great. We have more graphs we want to show you. We want to show you all of our documentation.
And keep in mind, we also sent with them detailed instructions about how to interpret those graphs because we knew that they weren't going to necessarily know how to do that. So we tried to reach out to them to say, what questions are you trying to answer so that we know what kind of documentation to provide you? Here's how to interpret all these graphs that we're sending you. So each kid's packet for each data service had that explanatory page on it that explained to them what they were looking at.
Yeah, that's a really good point. So as behavior analysts who tend to be a little overly prepared for things, as compliance-minded people, we did try to send everything we thought would be valuable. They had already had access to the treatment plans because that was their model. They had pre-authorization. We sent them all this graph data. Cut to many months later when they send back a letter basically saying, hey, you failed to substantiate all of the dates of service that we looked at. Please give us back $780,000. As Michael mentioned, the revenue size of the organization, this is not a huge organization. That is not a small ask. That's make or break amounts of money. And had a great healthcare attorney that we worked with. Good thing Michael and his co-owner were both kind of people were not just, oh, they asked for it, I guess that's it. We just have to pay them back. We started to enter into some negotiations with them to talk about, hey, what do you need? We don't think that's quite right. We feel pretty sure that we have everything you need. And when they showed us their sort of analysis tools, the spreadsheets they used, all of it said is no documentation, no documentation. So where we were was we had submitted a boatload of what we felt was really sufficient documentation, and they had assessed that, in fact, was not sufficient documentation. It was not robust in any way. It did not work. And please give us back $780,000.
When they were talking about the kids' data on the standard acceleration chart, I think one of the people from the insurance company actually said, so you expect us to read all those squiggly lines?
Yes, they in fact did say that. Yeah.
Yeah.
Great. So I know we have a couple people here with us today. Just want to pose a question to the audience. What do you think happened? What do you think the outcome was for this organization? We gave them our graph data. We gave them what we thought we had. They had treatment plans and they asked for $780,000 back. We didn't have other documentation to give them. Where do you think we landed? And you can throw it in the chat or
just throw it in the chat so we can see. Jasmina's typing, thank you. Christy's typing, thank you. Pay the recoupment, very reasonable idea. Negotiated and paid 50. or less. Hope you continue to fight it. Okay. Great answers. Thank you. Awesome.
Great answers. All of those are very real outcomes depending on what you have for yourself. Where we were, we had some negotiating power, right? I like that somebody thought, could you negotiate it? That's a really good point. I think a lot of people, when they get the letter back and they see the amount, they're just like, I guess that's it. I just have to pay that this isn't up for negotiation. They're the insurance company. They have all the money. They get to be the bosses. So that was one potential path. Continue to fight it. Yes, that was definitely a path. And spoiler, that is the path we did take. Sometimes you could ask for a payment plan. So if someone were to say, I don't feel I have any negotiating room, you still could ask for a payment plan. That could have been an option, but that was not the option we took. What actually happened was we did continue to fight. We had no repayment at all. We paid back $0. We were put on prepayment review because they wanted to see that we could change our systems going forward. And they had us on prepayment review during this audit time, and they had released all of those funds. So that is absolutely a fair guess that we paid the whole recoupment. Given what I literally just said to you, I sent them graph data. I thought I was so fancy in giving them, I know you don't know how to read my graph. Here's a way to read my graph. You had treatment plans. We had robust clinical systems. We felt really strongly like we got this, and we did not have this for them, but we did have some things. We had a lot of things in place that helped us to turn what could have been a $750,000 recoupment into a $0 recoupment. So we want to talk with you a little bit about what those things were that we had in place, and I will be fully transparent. When we're talking about the 7 elements of a corporate compliance program, that's a framework that's widely accepted in the compliance world, that a fully functional compliance program would have these 7 elements. At the time of this, I don't know that I even knew that there was such a thing as the 7 elements of a corporate compliance program. But what I learned, and I think really helped us, was they're not far off from what we as good clinicians know should be in any good program. So we had a lot of systems in place that aligned with these 7 elements, even though we didn't know to call them by the 7 elements. We didn't talk about having a corporate compliance program quite this way, but we had all the pieces in place, and it saved us $750,000. So we're going to talk through what those 7 elements are. Michael, I'll let you take the lead on this one.
Yeah. So like Rose said, these 7 elements are commonly accepted within the compliance world as what you need to have in order to have a robust, fully functional compliance program. And I just think it's important to echo what Rose was just saying, which is do not start building your corporate compliance program only when you think you can make it perfect. It is better to have an incomplete or not fully developed compliance program than to not have one at all, because in all likelihood, you are required either by law, regulation, or contract to have a compliance program, especially if you're taking any kinds of federal funds. So anything with Medicaid, anything through school districts, anything through an insurance plan that's subsidized at all under the ACA, you're required by law to have them. So what are the components you need to have? The first area, you have to have written policies and procedures that relate to compliance, things like codes of conduct, protocol standards, etc. You also have to have some kind of compliance leadership and oversight of what's happening in terms of compliance within the organization. That sometimes shows up in orgs as a compliance officer. It can also show up in larger orgs as a compliance committee. It can look different ways, but some bodies who are tasked with looking at compliance within the organization.
We had me as the compliance officer. I will tell you also in full transparency, had I known then what I know now about what a compliance officer's responsibilities are, I would not have said yes to having that title, because it is a big responsibility, but I didn't know any better, and it worked out for me. But that was a half-time position. I still had a half-time clinical position. The organization wasn't big enough to fund a full-time compliance officer. To Michael's point, if you're not a big organization, don't feel like that means, well, I guess we just don't get to do that one. You can outsource bits of the compliance program to 6 different people who just have different strengths that you feel like that's going to work for, as long as you have some coordination of all those moving pieces. In terms of written policies and procedures, again, we had tons of written policy and tons of procedure in terms of clinical, because we have very robust clinical systems. I was able to connect a lot of the compliance into those existing procedures, which I think was really helpful for us in terms of getting buy-in from our staff, that compliance wasn't this offshoot thing that we worried about some of the time. It was baked in, but we didn't have any kind of big giant binder or folder that was like the compliance plan. And still, we made out pretty well for where we could have landed.
Yeah. You also need to have training and education for your staff related to compliance. So for example, it's not enough to just have policies related to HIPAA's privacy rule. Everybody's got those. It's not enough just to have those. You're responsible for training your staff on those and documenting that training. So compliance or training that's related to compliance, you need to have, this is super important, effective communication lines. Like if nothing else, have a way for your clients, your staff, their family members, your vendors to report to you anytime they have a concern that's related potentially to compliance or ethics. You want to know about those. That's part of having effective lines of communication. Within the organization, you need to have a culture that really fosters and reinforces open dialogue. You need to have standards related to compliance, and you need to have disciplinary guidelines that specify how you're going to handle compliance violations that are differentiated, meaning you don't have just one standard that says will be disciplined up to and including termination. No, they want to see that you're differentiating, that you understand which types of compliance violations are more severe or more significant than others. You should also have ways of reinforcing behavior. You need to have auditing, monitoring, and risk assessment around key compliance risks that you face. And you need to have ways of responding to any problems that you might be picking up. That's things like investigations, corrective actions, et cetera. So if you have all 7 of those elements, and again, they don't all have to be perfect. You may even be missing one of them, but if that's where you're trying to get to, you're trying to get to having at least some things in all 7 of those areas.
Yeah. And again, thinking of where we were at the time, it was not as sophisticated of a compliance program as we would build today or as got built over time. We did really well on incentives. We built incentives into all of our systems. We had auditing and monitoring, really more monitoring than audited. We were checking everything all the time, 100% of all of our samples. We had systems in place, and we had performance-based bonuses connected to your team's data for the compliance checks being at or above a threshold. We probably were not as robust in our disciplinary guidelines as we now know we should have been as behavior analysts and as a group who is really pretty tight-knit in terms of verbal community and a clinical community. We behave like behavior analysts for a lot of things. Oh, you consistently aren't meeting this compliance expectation. Let me write a behavior support plan for you. I will help you through this. We know how to shift behavior. That's great. We're not saying you shouldn't do that, but you also have to have a clear boundary of where this kind of violation cannot be accommodated around. We cannot behavior support plan you around it. We can't performance improvement plan you around it. Some violations really are just too egregious. Now, we didn't have any of those kinds of violations, but in being honest with ourselves, that was a place we had room for improvement. Like I said, we had great monitoring systems. We had lots of rubrics for teams to check on compliance in different ways. They were checking on client files. They were checking. One of the reasons we felt so sure that our standard acceleration charts were going to function as documentation is because they are standard, meaning what goes on those graphs always is the same. If you see a dot on a graph, it always means the same thing. If you see an X on a graph, it always means the same thing. The dates are always in a certain spot. They always cover a certain amount of time. And we had systems in place where once a month, our teams were going through their graph data and making sure that all the pieces were in place to keep those graphs standardized. So when we negotiated with the insurance company and they said, well, how do you know that's what the date is? Let me show you how I know. How do I know that date wasn't added the day after? Because I have a checklist from 2 days after that showed they checked the dates on that and it was correct. So we have robust monitoring systems that really did save us in the end because we were able to show this particular funder we had all the things we needed. And again, I think because we're behavior analysts, we had what we would think of as common sense responding to detected offenses and responding to the data, right? What we know how to do is we know how to measure, we know how to look at the data, see what it tells us, and phase change to move things, to fix problems, to move things forward, to do all the things. So we incorporated the same practices in this compliance world, and it really worked out for us. And how we got to the $0 recoupment was many negotiations, a little bit of mediation, and a meeting with a lot of lawyers and compliance team members at the insurance company, and me literally walking them through. I could write you a note based on what's on this graph. I could tell you exactly how many practice timings this client did, what their score was yesterday, that this was improvement or wasn't improvement. I could tell you the date. I could tell you the interventions that were used. And because I was able to show all of that, they conceded that, yes, in fact, your documentation does demonstrate what it needs to, but we will not accept it going forward. And we did, in fact, have to change our documentation and move to what is standard practice now, which is a session note. In those days, session note was not standard practice everywhere.
Well, to be clear, we didn't give up our standard acceleration charts. We just created a very low effort way for staff to take what was on the charts and to get it onto something that's a note.
Yeah, which is what you're all doing now, right? I think about this a lot. You maybe don't spend too much time in other compliance trainings. When you hear about documentation trainings in other parts of healthcare, they're relying on that session note for a lot of things that, as the actual analysts, we don't. In other fields, they rely on that note to communicate to other people what the session looked like, how well it was working, and all of those things. And we rely on our graph data. I look at a graph to say, is this program working? Do I need to change the intervention? That's a little bit unique to us. I think it's probably everybody's practice. We have the data that we make decisions on, and we have session notes because they're a requirement. I have a CEU code up here for behavior analysts collecting BACB CEUs. We are offering CEUs for the live participants only. So if someone ends up seeing this as a recorded event, the CEU will not be available, unfortunately, but here's the code. Please write it down. And Michael or Josh, do you want to mind throwing that into the chat, just if anybody wants to copy? Thanks, yep. Michael. Yep. All right, so prompt to the group. Thinking about documentation, it is the biggest risk area in our opinion, and I think in the opinion of a lot of people in the field. It's the biggest risk area a health provider faces from a compliance standpoint in a lot of ways, right? Because one, in order for your organization to be sustainable, you have to not just make money, but you have to keep that money, right? Like, we made money. Apparently, we made at least the $780,000 that they asked back. Although, fun fact, they actually did, in fact, ask for more money back than they had ever actually paid when they extrapolated their results, which is a thing that comes out of an audit. They do what they think is a statistically valid sample, and they then generalize those results and say, if your errors were that big in the sample we looked at, that is what your errors must be across all your documentation. So they ask for it all back. But in order for you to be sustainable, you have to be able to keep the money you have made, but also your documentation has to show that you are engaging in ethical and compliant healthcare practice. It's not just about billing. It's really about showing that the service meets basic standards for the healthcare service we're delivering. So when we're thinking about documentation, question to the group, please throw it in the chat. What are the things that keep you up at night? What worries you about your agency's documentation? Or what have you seen in other organizations you've worked in that you thought, oh, I'd be worried about that if I worked there? What do you think are areas of worry in documentation?
Christy's answering. Thank you, Christy. And if you're not worried at all, feel free to put that in there.
Oh, yeah, please. If you are like, yeah, our systems are down tight, tell us that. We would love to hear that.
Jasmina's typing. Thank you, Jasmina. No data collected during the session, Jasmina? Yeah, or at least shown in the documentation.
Yeah, that is a real issue. I have worked in organizations where the behavior technician maybe just didn't understand that, no, if you actually can show no data, that looks like you did not deliver the service, no matter what words you write on a paper, or your technology fails and you think you've collected all the data and the data doesn't get pulled into the note, and the technician doesn't know to write a statement of there was a technology error and I actually did collect data.
Yeah. Corrine also brought up timeliness of completion and not having all the requirements of what should be in there.
Yep. I would say we agree with that. We've seen that quite a bit.
And Christy, that our technicians don't tie their note to medical necessity, illustrate the billing code, or corroborate the service, and that they don't write boneheaded things in the note. Yeah.
Yes.
And accurate and timely. Excellent responses. Thank you, guys.
Thinking about your notes, we see a lot of mentions of the BTs. We'd like to see people's experiences. Who do you think in your organization, who do you think writes better notes? Whose notes do you feel a little bit more confident in?
The techs or the analyst? Part of what Rose and I do in our work at ABA Compliance Solutions,
Yeah.
we audit other ABA agencies. So they hire us to come in and audit them. Joan says the student analysts, if people are maybe studying for their credential or moving towards their credential, but aren't quite BCBAs yet.
I have to say I have seen that.
Yeah, that they write better notes. Yep.
Yeah.
Corrine, the clinicians. Okay.
When you say the clinicians, do you mean your master's level clinicians? Yeah. Okay. I think looks like Christy's thinking too. We audit our tech notes more robustly and it's easier to identify errors for techs. Yeah. So our findings in our audits, and we audit across big organizations, small organizations. We audit lots of notes. We've audited notes when we work together clinically. Your technicians are writing better notes than your behavior analysts. Like, I'm not saying it's 100% true. I'm not saying it's never the case that we found, but our experiences, the technicians write better notes than the behavior analysts.
Yeah.
I think the technician's scope is much more tightly constrained, right? So they have fewer kind of tangents to go on to. They do one thing and one thing specifically the way it's been prescribed, hopefully every day. So they're not reinventing the wheel every day. The behavior analysts in our experience tend to write as if either they're writing for another behavior analyst only, and that's the only other person who's ever going to see their note, or as if literally no one is ever going to see their note and they just have to do it because you told them to. So it's been an interesting finding in our experience. I will say it makes sense to audit the tech notes more robustly because they're the greater volume of your overall service delivery. So if you get hit on your tech notes, even though per unit, you're very likely getting billing a smaller amount per unit, they're just doing more work in a week than your behavior analysts are. But your behavior analysts, they aren't the skilled writers that we would hope for, I think. For a lot of reasons.
I think what we also see is that a lot of agencies will do a better job. I don't want to be judgy, but they'll provide more cues, the more SDs into the behavior text notes that will occasion the kind of behavior that they want from the text. They do that more often for the text than they do for the behavior analyst.
Yeah, that's a very good point. We see a lot of templates where it's a lot of free text for the behavior analyst and very little free text for the behavior technician. Someone had pointed out, like, no data collected. Yeah, your technician note looks really weak if their data doesn't get pulled in because that is the bulk of their note where it's not for the behavior analyst. So we want to share some common documentation mistakes we've seen in our audits that may resonate with you, may not, and just start the discussion there. Michael, do you want to take this one?
Oh, yeah, sure. Christy had mentioned the words corroborate, illustrate, and substantiate. So that's where these fall into. These are not all the common errors that we see. They're just some of the most common that we see. So for example, in terms of corroborating, and corroboration means you are providing evidence that a unique healthcare service was actually delivered. We've got a date, we've got the times, we know who was there, we know who delivered the service, we can identify who the client was. That's all corroboration. And one of the most common errors that we see is people using estimated or rounded start and stop times. So instead of saying if the session was scheduled from 1 to, let's say, 4 o'clock, they'll put down 1 o'clock as a start time and 4 o'clock as a stop time all the time, or 2:30 to 3:30 instead of 2:32 to 3:09, the actual start and stop time. So that's one of the biggest weaknesses that we see. And then another that we see in terms of illustrating these essential code elements, what that means is, so your note has to corroborate that a unique healthcare service took place. It has to illustrate all the things that are essential to the CPT code that's built. And each CPT code requires that different things be documented. So if you don't illustrate all the things it requires, then the CPT code wasn't justified. This happens with code 97155. And what we'll see is no protocol modification needed.
No,
right?
no protocol modified today.
Yep. And what the BCBA is trying to say is the kid is appropriately placed in their program. They're in the right place in all their curricular sequences. I don't need to advance anything. I don't need to change any parts of the IV. I don't need to back up. The kid's just good. The problem with that is that code requires protocol modification. It requires it. And so if what they're saying in the note is no protocol modification required, then it shouldn't have been billed as 97155. And by the way,
you essentially wrote a note that said, I didn't do the thing for this code. Pay me for this code.
Yep.
Now, we're not trying to say that you have to make a change every time you are out for a supervision session, because as most of you I'm sure know, we have guidance from, for instance, the ABA Coding Coalition of all of the activities that go into protocol modification. So it's not just the making the change, but if you're not documenting those things and you wrote the words, no protocol is modified, as I just said, you essentially wrote a note that said, I didn't do the thing for this code. Please pay me for that code. So it really is about how you document what you did versus documenting what you didn't do.
Yeah. And by the way, we have a free resource for you at the end. There'll be a QR code. You can go pick it out. It's a multi-page handout that goes through these problems and a couple others, explains why they're problematic, and gives suggestions for how to fix it. So hopefully that's helpful to you. And then I think another common one that we see is for CPT code 97153, where what gets described really doesn't sound like healthcare or treatment at all. What gets described sounds like caregiving. So they'll say things like, Kevin enjoyed playing board games today, or Sheila had trouble being patient at lunch. So that is a problem of failing to establish the medical necessity of that particular day, of that particular visit.
I think we see this in all kinds of notes. I feel like we see it a lot in clinic-based services, not exclusively. We see them in the home-based services as well, but I think an issue that can come up in the clinic-based services, often you have a very nicely structured clinic day. You're prepping kids to get into a less restrictive environment like a school. And so you'll see reference to scheduled activities that very likely had treatment embedded in them, but they're not described that way. They're described as went to recess, ate lunch, went to the bathroom. And
went to circle time.
To the treatment plan goal that's connected to my behavior in the bathroom, to the treatment plan goals that got implemented during circle time. So we see that a lot in the 5.3 notes, but I will say that's not unique to the 5.3 notes. I think we see very similar issues with parent training notes, for instance, where they're just not reading like training parents. They're reading like something else, a progress review, a check-in, and coordination. So we see it. It's not unique to those 5.3 notes. To Christy's point, auditing more robustly in your 5.3 notes because there's just so many more 5.3 notes in a day. So that's certainly something we see. And I think related to the medical necessity, I just want to call something out here. There's a lot of talk in the field about medical necessity, which makes sense, right? We're healthcare providers. And a lot of that is tied to getting authorization, that you're establishing medical necessity through your treatment plan, through authorization. That's all absolutely true that you have to do that. I'm not telling anybody anything they don't know. When you're having to ask for an authorization for services, we have to establish medical necessity. But your note establishes medical necessity in a very different way. And it's to what we're saying here on this particular error. It's connecting what happened today to that treatment plan. So sometimes it's clean and easy in the 5.3 notes because you actually pull the data in, so the treatment plan goal name is in your note. But again, often in your behavior analyst notes where they're doing some more free writing, they're not doing as great a job as connecting what I did today to that treatment plan and showing that's why it was medically necessary today. Something just to consider and think about there.
Yeah, and one thing I want to add here before we move on is I do a lot of software demos with a lot of different solutions out there for ABA. So I've seen what's possible. And one thing that's available on the clinical side too is you could have the best policy that covers everything, the best incentives, the worst consequences, have everybody educated and sign off But at the end of the day, we're all human. We make mistakes, so people can step outside of those policies. So it's really important to look at the software solutions out there and see what kind of guardrails can you put up around to try to eliminate the human error as much as possible. Because like I think I've seen before, you mentioned the time, making sure that they're starting and stopping at the right time. There are software solutions out there that can do that for you automatically, so you don't have to worry about documenting the exact time. There's AI session note reviewing platforms that brag about never having had a clawback because of their AI session noting. And I've seen some really robust systems that won't just tell you that it needs to be reviewed. They'll tell you exactly what's wrong with the session note. So there's a lot of software tools out there that can help put up those guardrails for you and for a lot of this stuff.
There is, and I agree. I think software can be a fantastic tool, but I also think, and I don't know what you think about this, Josh, but I also think if you don't know what the software is supposed to accomplish for you, then you may not necessarily know whether or not it's actually accomplishing that. Like, we run into clients.
Totally agree.
Yeah.
We call that keeping the human in the loop. So you don't want to trust AI. You don't want to just blindly trust your software. Like, you have to understand what it's doing for you. And you always have to some extent, be reviewing like making sure that it's accurate, because AI makes mistakes, software makes mistakes. And at the end of the day, if the regulatory bodies aren't going to hold the software accountable, they're going to hold you accountable.
Right.
It's a tool, not a replacement for the human.
And I think you make a really good point, Josh, also in that, like, sometimes it's as simple as the settings you have set up in your software, and some will let you do some things and some won't. What we find when we've shared our results with our organizations is, on our notes, the way it's set up is the time that gets pulled into the note is just what's the scheduled time. So unless you change the scheduled time, that's what shows up in the note. That's a setting. You could potentially fix that, or you could make it so that the process is I manually verify the time and modify it if it wasn't exact. Because we're not saying nobody's ever started right on time and ended right on time. Excuse me. But what we see is every note is exactly 8 o'clock start, 12 o'clock end. And we know that's not true. That's just not the reality.
That's not how the world works.
But that is a really good point. Right. So we wanted to share a list of why we feel some of these documentation fails happen. Where do these errors come from? And again, these are based on our experiences. And I think a lot of it is most of us were not taught how to write. Most of us were not taught to be medical providers. Now, some of us are a little bit older. And so when we were in grad school, we in fact were not healthcare, right? So nobody taught us how to write health. We weren't healthcare at the time. We just became healthcare overnight one time. But I don't know, even behavior analysts I see who are being trained now, I'm not saying there are no programs that are doing this. I'm saying a lot of the programs are not training you to be a healthcare provider. They're training you to be a really robust behavior analyst, because again, ours can be applied all over the place. Just in this context, it's applied in healthcare, and none of us were taught what that means, and how writing a treatment plan and writing a treatment note are two very different things, or how summarizing your assessment results and writing a session note are very different things. So we see that as a place where people struggle. Also is the case, we tend to train what we know, right? So as behavior analysts, we have this beautiful science behind us that has taught us how to train other people to understand things and how to do things, how to shift their behavior in really meaningful ways. But if I don't know what's expected as a healthcare documenter, then I'm only going to train what I know. And so then we have this sort of train the trainer effect of, I have trained my staff beautifully, but I forgot to tell them these 3 really critical things. And so my staff still don't know, even though they have been well trained. I think another thing we come across is that we were also not trained how to read policy language. Your funder will hand out a policy. They'll call it the ABA policy, and it is not super clear. It is often intentionally vague. We weren't taught how to read that or what that means or how to interpret that. We weren't taught how to read contracts, but here we are in contractual relationships with very big organizations, healthcare providers, health insurance providers, that they have somebody there who knows how to read a contract, probably. It's like 100% the case that they will have someone who knows how to read that contract. And depending on the size of your organization, you may or may not. We were not taught how to read regulatory guidance. And the regulatory guidance in our field is shifting rapidly. At the time of our audit story, there was another funder who to say their policy documents were updating literally every 3 months. So what was happening in those days is as these auditors came out and found how people were actually practicing, because they didn't know what we did, they would see a practice and say, oh, we didn't know that's what you meant. We didn't mean to say we would pay for that. Let's go update our policy. They do another audit that would take a couple, 3 months. Oh, we didn't know you all did that. Their policy would change. As licensure for the individual behavior analyst came in, that changes a lot of things. That's new for a lot of us. We weren't taught how to read the regulations that came in with that. So we weren't taught how to do these things. I don't know a ton of behavior analysts who have a ton of free time on their hands at their jobs that are like, oh, I'm just going to go do a couple non-BACB CEUs where I can learn how to do some of these things because time's a precious commodity. We don't have it. And I think the other thing we find is that as behavior analysts, we were taught that the BACB was the end-all be-all of regulatory guidance. That is as long as you are adherent to that ethics code, you are fine. They oversee individual behavior analysts. They have nothing to do with the organizational level. Their job is to protect the field of behavior analysis. That is not the same as engaging in this regulatory world and engaging in these contractual relationships. It's just very different. And so I think that's another area where we're just struggling to know how to do things differently. So given what we know about documentation being hard, you guys have all shared the concerns you've faced. What do you all think you can do now to improve things? If you're feeling like, hey, I have some of these concerns with my documentation, or maybe you don't, and you just want to be kind and share with the group things you've done to not have these problems with the documentation, what do we feel like we can do right now to improve some of these errors?
Just go ahead and drop those ideas in the chat if you have them.
Thanks, Michael.
Come on, you got to have some ideas.
Everybody is, if I knew, I wouldn't be sitting at your webinar today, guys. I wouldn't be in your live stream if I had that answer. Christy's having an idea.
Jasmine, maybe if resources weren't, there was no limit on resources. You could do whatever you wanted. Maybe that.
Yeah, that is a good point. There's a lot I could do with a lot of resource and what I feel like I could do with not that much resource.
100%. Jasmine is writing. Thank you. Christy's writing. Continue to identify where documentation is less robust or not meeting internal or external requirements, and update training and education within the org. Excellent. Yeah, and then shift your auditing efforts towards that. Follow the errors. Devote the resources there. That's great. Definitely look more into ensuring that medical necessity is in there. Really good, Jasmina. And that, again, that's tied back to two primary things, Jasmina. It's how did what that person did that day, how did that relate to the treatment plan? And did what was documented, did that substantiate the encounter length? So if you only did two things in a 4-hour session, there's got to be something in there that explains why that happened, just as an example. But with medical necessity, you're looking at tying it to the treatment plan and substantiating the length of the encounter.
Yeah,
revamping training for notes across treatment codes and ensure they meet payer expectations. Kareem.
Michael, to the point you just mentioned about the 2 programs in 2 hours or 4 hours, for the behavior analysts in the group, I bet any one of us could think of the conditions under which that's absolutely 100% appropriate. The problem is, it is not a behavior analyst reading your note. They just are not. That's not who's auditing our notes. So your documentation has to do a lot of work. They're not going to come in with, it's one place Michael and I actually have to reel ourselves in a little bit when we're auditing for organizations is we sometimes can understand why a note might look a certain way because we have the context of what a session looks like, what a client, we could tell in just some of the information, what that demographic of client might need in a session, but that's not, you're not going to have that benefit when someone else is reading your notes. So yeah, I love the ideas in the chat. I just want to connect them back to these 7 elements that we talked about. I hear people talking about what's essentially auditing and monitoring, which is I have to look at my documentation to see where are my errors, where is there room for improvement, the connecting to medical necessity. So understanding the standards, that's really going to come back in some ways to training and education, some ways to your written policies and procedures, and just knowing what the actual expectations are. And a lot of connection to training and education, which given the areas we've seen and what we talked about is some reasons why it might be the case that we have some room for improvement in documentation. It really makes sense. We just weren't taught how to do this. And so focusing your efforts on training and education really does matter. And Michael, to your point, you were saying before about, yeah, if we had unlimited resources, we know you do not have unlimited resources. We understand that. But one thing that kind of helps show you have a robust compliance program is being able to show that with whatever resources you have proportionally put some towards compliance, right? The expectation is not that every organization has the same size or complexity of compliance program. In fact, the guidance that comes from the Office of Inspector General says very specifically, it should be scaled to your organization's size, complexity, and operations.
And risk.
If you have a compliance program that looks giant and you're a 4 clinical staff, including your tech organization, that's actually not better for you because that looks like it's probably not actually how you're doing things. But also if you have a very big organization and you do not have a fairly robust compliance program, that doesn't look good for you either. And this looking good for you, where that actually matters is if and when the bad thing happens, your ability to reference back to your compliance program is what gives you negotiating power in the consequences. Back to our story. The fact that we could show we have trained our staff, everybody uses these graphs the exact same way. We audit these graphs. We monitor all of this documentation. We can show you all of the times people were trained. We can show you all of these things. And we can show you the policy. That's what put us in a negotiating position. That's what it enabled us to negotiate from that ask all the way down to, no, in fact, you don't owe us anything, but yeah, you have to change your documentation going forward. So when we talk about this compliance program, it's not just, I want to have it like an insurance policy in case somebody comes looking. You want to have it because it's going to protect you when somebody has an opinion about what you're doing in your organization. They're giving us a lot of money to provide our services. They're going to have an opinion about what we're doing in our organizations. That's just what's true.
And one thing I want to highlight about when you talked about having a compliance program that doesn't fit your business, like having one that, if you're a really small business and having a really big compliance program that is going to make them look into it, and you don't really operate that way. So there are state requirements, HIPAA requirements, payer requirements. There's all these different requirements you have to follow. And that's why you need to be cautious when using like templates. You have to don't just take templates and think, oh, I've got my compliance program and it's done. Whether you're using, so we tell people you can use ChatGPT to help write your policies. You can get templates, but no matter what you do, you have to look at those policies and you have to make sure that they actually, like, if you have a transportation policy, whether you provide transportation or not, your policy could be, we don't provide transportation, or whatever the case is, whatever the category is, make sure that it actually describes how your business operates. And it's not just this document that's sitting there just so you can say you have it.
You are in a worse, to your point, Josh, you're in a worse place in terms of risk and compliance if you've got this manual sitting up there and folks start looking and it doesn't reflect what you do. That's actually worse than not having a policy. I'd rather you didn't have a transportation policy than have a transportation policy that you weren't adhering to.
Yeah, absolutely. Yeah. And we agree, Josh. We don't recommend people buy policy manuals in whole generally, because you're still, the amount of work you have to put into them to make them reflect your practice. You probably could have written yourself a policy that maybe isn't as slick, maybe doesn't look as fancy, but actually reflects your real work, and that's puts you in a better position. So
we have a term that we say in compliance, done equals perfect, because if you wait until it's perfect, you probably waited too long.
Yep. It's a really good point. So if we think about an action plan for organizations who maybe are thinking about how do I improve my documentation practices, you have to educate yourself on how to read the policy language related to documentation. If you don't know what's expected, you can be the best trainer in the world. You will have trained not to the expectation. That doesn't help you.
Yeah.
You need to ensure that you understand the full range of oversight bodies that you're accountable to. And to your point, Josh, it's not just at the federal level. It's not just your funder. It's the state. It's the licensing. In some states, there is an organizational level license to even provide behavior analysis. In some states, it's not. Some states you have to have, if you have a center, you have to have a license to be a daycare center, even though we all know that doesn't track. There are a lot of oversight bodies that have an opinion about the work we do as healthcare providers. You have to develop an auditing and monitoring plan. To some of the points we saw in the chat, if you're not looking after the fact, you will not know what you're going to get into when you get audited. And I want to be very clear, if you have not been audited yet, it is luck, it is coming. The contingencies make sense, right? The amount of funds that are going back and forth in healthcare of course, any responsible funder is going to want to look to see, are you appropriately using the funds? And if you're taking those public dollars, they're required to look to see if you're appropriately using the funds because somebody's looking at them to see if they have appropriately handed out those funds. So it is coming. It's not a matter of if, it's when. You need to provide your staff with additional training. And that's not training for training's sake. It's not just for skill building, but that's a risk mitigation strategy for your organization. It's not just about, we want to have the most, clinically sound and robust behavior techs and behavior analysts. Of course, we all want to have that. But the risk mitigation in building those skills is protecting you when that audit comes around. That's really goal of this particular amount of training. And then you want to ensure your note templates allow for and prompt for the information you want in those notes. We see this all the time where there's literally just no spot to document some of the things. There's no prompt. There's no box that says, document who else was present for the session, or document how many clients were receiving services from this one technician during a group code. Nobody's going to just think to put that in. If you didn't ask for it, they think you don't want it. So those are going to be some really important steps you might take for the action plan. And then I want to pop up the next CEU code. And Michael, if you don't mind popping it into the chat.
Yeah.
And then Michael and I at ABA Compliance Solutions, this is what we do. We loved the field of behavior analysis. We liked clinical practice, but had done it for a long time and we're ready to move on, but we still wanted to support the field. And this is what we do. We support ABA organizations in meeting this compliance stuff. We went and got the extra training because we're a little bit dorky and liked it, and also knew we had to if we wanted to really understand what's going on. We do have some supports we can offer, so we'll go through those, but I wanted to just leave some time for questions if anybody has questions before we get into that. I know we're coming up on time, so I want to make sure we leave room if people have questions about this or anything else.
Yeah, while they're typing, I'm really glad that we got to connect just because we're really good with the IT compliance side, technology, but we really need people that we can refer people to for the clinical compliance side because it's just as important.
Yeah, and we're so happy to have connected with you as well because we see it all the time. We'll have people reach out to us and say, we think we're good on everything. We just need HIPAA compliance. We're like, well, that's probably not exactly true. And also, we have partners who can help you with some of that HIPAA compliance because the technology piece it's not easy for everybody. It's not firsthand knowledge.
Okay. And you can't just buy compliance. Like you can't just go to a compliance store and just buy it. And I think that's a big misconception that I see all the time. Or like the software solutions that have compliance, it'll say HIPAA compliant on or something. And that doesn't make you compliant just because you buy a sticker.
Yeah.
Yes.
That's right.
Yeah.
That's right. So that's a QR code for the free resource. If you guys wanted it, it's just like a little support packet that points out the common errors that we went over and then some others, explains why they're problematic, and gives some suggestions as to what folks can do to try to improve that. So that's available at that QR code on our website, and feel free to use that. This is your CEU quiz code. So please go ahead and open that page up because as of probably Monday, we're going to shut that link down because, as Rose mentioned earlier, we're only offering CEUs to people who attended live, not for folks who are watching this at some later date. So for those of you who are here, please go in. It's a really quick CEU quiz, the CEU code numbers. Go ahead, get that done. Our system will automatically shoot your certificate out to you, but we are going to be shutting down that link in probably, let's say, 4 days.
Yeah. All right.
And also, I just want to let y'all know we are launching a series of quick guides, which are highly specialized, highly directed, very to the point trainings around the common documentation errors that we're seeing as we're doing these audits of ABA companies across the country, like we said, from very small to very large. They're going to be structured so they're going to be very accessible price-wise, and you can purchase either the BCBA bundle, which includes a foundations course and then all the CPT codes that behavior analysts bill, or the BT bundle, which is the foundations and the codes that they bill. And information about that is available on our website if you'd like that. And then one other potential support for you is we are launching a membership community April 1st, 2026. It's called the ABA Compliance Connection, and it will be only for folks who are interested in compliance within the behavior analytic sphere. It's a place you can come and get support. We'll be offering guided trainings. We'll be offering guided challenges. We'll have monthly office hours, ask me anythings, etc. Oh, Which code did you need, Jasmina? The second one or the first one? Oh, the QR. Good. Thanks,
QR.
Ryan. So if
Yeah.
you're interested in the quick guide documentation course, or you're interested in the membership community, just drop by the website, abacompliance.com.
Yeah. Our goal for the community is a
Thanks,
place
Josh.
to learn this stuff without having to go acquire a bunch of compliance credentials. When we say guided challenges, what we mean is, the first one we have planned is, let's take a revamp of your templates. So we're going to guide our members through, let's look at what your documentation templates look like. Let's see where they're prompting for what you want. Let's see where they're not prompting for what you want. Let's suggest tweaks. You'll have time to go make your tweaks, bring them back, get feedback. We are behavior analysts. It's built very much like a behavior analyst, trying to teach people how to do some things. It really is meant to be a place to learn and not feel silly for not knowing that.
Yeah.
That perfectionist piece we all have is for real, and we really want to make people feel comfortable to raise their hand and say, I didn't even know I was supposed to ask for that. Help me fix that.
And a place to get some trusted guidance too, don't you think?
Yes.
That idea of like, you're talking to other people who are trained in compliance, interested in compliance, doing compliance. So it's a place to find that bit of community as well.
Yeah. And we're available for consultation. We have monthly partnerships where organizations can partner with us to reserve our time. Basically, you get 5, 10, or 20 hours a month with us, depending on what you need. If you're like, hey, I'm ready to build an actual robust compliance program, I want my 7 elements, the monthly partnership might be for you. The community might also be a place for you to do that. So we're trying to make compliance accessible in a lot of ways, because we know it isn't, and we know you guys don't have, like I said, a whole lot of free time to just take up another credential. So yeah, and I will put the CEU QR code back up. And yeah, Josh, thank you so much for having us.
Thanks, everyone.
Yeah, I'm really glad to have you guys on. And just for everybody who has ever heard me say anything negative about consultants, Michael and Rose have our seal of approval. These are good consultants. If you need anybody who's building a compliance program, should definitely reach out to them.
Oh, we appreciate it. Thanks, Josh.
So,
thank you.
So,
Bye, everyone.
thanks for joining us. Have a good day.
You're already doing the work, investing your time, your energy, and your vision. So let's make it count. Build something that works without breaking you. The EBCBA Blueprint is the way. Get started for free with our foundation course.